Let's move on to the next session. Uh, Small change. Dr. Abraham Oomman-EP will talk on Go with Guidelines, ACC 2022 and ESC 2021 guidelines. Let me invite the panelists for the session. Dr. Chandrabalan sir, Dr. Ramakrishnan sir, Dr. Ranganathan, Dr. Prabhu Venkatesh to take the dais and coordinate the session. Thank you.
Shall I start? Can I start or?
Yeah,
Okay,
please, sir.
thank you.
Please.
Okay, thank you very much for the invitation. My topic, as Dr. Lawrence said, is Go with the Guidelines, ESC 2021 and 2022 ACCH Heart Failure Guidelines. This Heart Failure Guidelines, not atrial fibrillation guidelines. These are my disclosures. So I don't know how many of you would have seen this. This is Thanos, and youngsters might resemble or may understand and must have seen the movie. And there's a very famous dialogue, I am inevitable. Similarly, heart failure is inevitable to us all if we live long enough. And AF begins heart failure begets AF. But what is not inevitable is how we deal with it, how we treat it. And I was planning to give the slide because the topic was very specific, the guidelines, so the usual dry guidelines from the guideline committee. I was planning to show that, but today morning as the Heart Failure Association of India General Secretary, we had a meeting and we discussed two registries in our country. One was the Kerala Heart Failure Registry and second was the National Heart Failure Registry. And we said that many great things were discussed. We said that the guideline-directed therapy, that is 3 drugs, because SGLT2 inhibitors were not approved at that time for heart failure. So at least 3 drugs, and with 2019 to 2020, we increased our guideline-directed therapy to 48%. From 24%, doubled to 48%. So we were very happy about it, but there was one problem. 30-day mortality remained the same. So at that time, at least personally, I had an epiphany that what made the difference? The guideline-directed therapy increased, doubled to 48%. We expected significant reduction in mortality. The initial data was for 3 months, and maximum deaths in heart failures in 3 months. The reason what we thought, or I personally believe, is that even when ARNI was made available from India from 2016-17, but even then 2019-20 also, the ARNI use was very low. So when the ARNI use was low, if we give guideline-directed medical therapy, the mortality did not improve. And that is why I decided to tweak my talk. I would intersperse the importance of ARNI, because ARNI is getting to be very cheaper in about a month's time. So why we should give ARNI and weave it through the guidelines. So let's look at the ESC guidelines first. ESC guideline, look at the lower part. Sacubitril valsartan is recommended as a replacement ACE inhibitor in patients with HFrEF to reduce heart failure hospitalization and death. We all want to live longer. Very few medications we have, or therapies we have, including the therapies we discussed all day, they do not reduce death. The very few things, and one of them is ARNI. It reduces death, and in the paradigm trial, p-value is 0.00008, and it is equivalent to 2 trials back to back showing reduction in mortality. If anybody is interested, people, just very few trials or no trials look at mortality as a primary endpoint, because everyone knows that it's going to fail. So they put in 1, heart failure hospitalization good, but then they start putting 2, 3, 4, 5. Many of the, I'm interventionalist, but many of the interventional endpoints would have, including 5, 6 endpoints put together as primary endpoint. But ARNI reduced death. And this is a busy slide again. The biggest problem is when the GFR is down, we do not give, but the 2021 update says even if the GFR is less than 30, you can start, but with a lower dose. This one slide I want you to remember, because the biggest reason why we do not start ARNI is that the creatinine may be slightly low. And this is from the position statement published in Circulation this year. Up to a creatinine increase of 50% or a maximum creatinine of 2.5, minimum GFR of 30 and potassium of 5, you can up titrate. It's not stop, it is not reduce, it is up titrate and closely monitor. If the increase is more than 100% or the creatinine is more than 3.5 or the GFR has come down to less than 20 or the potassium has gone more than 5.5. So if the creatinine was 1, if it become 2, okay, you can consider stopping and see whether what happened. But otherwise, you can give it safely, but be careful about it. So the ACC AH 2022 guidelines said 3 things. You can see use, switch and value. So use where NYHA class 2 to 3 and when ARNI is not feasible. This is also important. When do you give ACE inhibitor? They said when ARNI is not feasible. So when do you give ARBs? When somebody is intolerant to ACE inhibitor and ARNI is not feasible. So again I repeat, ACE inhibitors when ARNIs are not feasible, the ARBs when ACs cannot be given and ARNI is not feasible. So don't jump on ARNI and say, oh, we are given. That's a mistake we have been doing as proven by the National Heart Failure Registry because we could not reduce mortality. And replace it early, it's a class 1B recommendation and the value is high. In heart failure with mildly reduced ejection fraction between 40 to 49, you can see here underlined, ARNI is a class 2B indication. And in preserved ejection fraction, again it's a 2B indication. Now let me go to the guidelines per se. There is what is called a stage A, B, C, and it's stage C which we often look at. But stage A is important because these are people at risk of heart failure. And who are they? Your diabetic patients, obese patients, your patients who undergo malignancy therapy. So oncology therapy, they are at risk, they are at stage A. And diabetes with one risk factor, the position statement says that you have to do the NT-proBNP and the troponin yearly. Then stage C is no symptoms but structural heart disease, and stage C is what we routinely say. And so that includes now the new terminology of heart failure with improved ejection fraction. Ejection fraction has improved more than 40. So diagnostic algorithm, again, natriuretic peptide is important, and the NT-proBNP more than 125, and what they have the definitions, reduced ejection fraction less than 40 is HFrEF, mildly reduced is 41 to 49, and preserved is more than 50, then improved ejection fraction, those who improve, and they can have various trajectories. Now biomarkers, who are used just for test for biomarkers? People with dyspnea, already hospitalized patient, chronic heart failure patients, and even patients at risk of heart failure. That's very important. Most of the people, and I see a lot of young faces here, apart from the very young people, even young people are at risk for heart failure. So if you think that somebody is diabetic, our relatives are diabetic, and they are obese or hypertensive, they come under the stage A, and sometimes maybe even B, and they should be evaluated. Another important thing is imaging. I'll skip echo and X-ray. The important thing is cardiac CT, CMR, and PET. And when they are being planned for device therapy or patient suspected cardiomyopathy, do that, we would be in for surprises. I had one patient who was airlifted for mitra clip, and you know mitra clip costs about 30 to 40 lakhs. She had the mitra clip, then she had atrial fibrillation, so she underwent a cryo, so total bill came to around 40 lakhs. Then still symptomatic, I was part of the, I looked for it, and patient had sarcoidosis. So, and what we did was a cardiac MR with a PET. Then another thing which we have to do is ischemia evaluation. But heart failure with ischemia, what do you call, revascularization is important. So you can do that. But the interesting thing in this guideline was that they said do this for detection of myocardial ischemia, not for detection of viability. We go gaga over my viability, but that may not be the case. Stage C, what they said was that start all four very rapid sequentially or at once. What are the four? ARNI, beta blockers, MRA, and SGLT2 inhibitors. There are different ways of doing it. Some people start SGLT2 plus MRA or SGLT2 plus beta blockers, then they start ARNI, then start MRA. There's a recent study called Strong Heart HF, which was presented and published in the AHA meeting about a month back. And that was the biggest topic of the American Heart Association meeting, because they gave low dose of all four drugs and they changed the whole scenario. So Strong HF is the latest kid in the block. I personally do that. I will decongest them rapidly and give all four at small dose, because if you do not start, then you will never give. If you don't start the initial step, you will end up never giving. And step 2 is reevaluate and see whether they are reaching the target doses. Step 3 is consider different scenarios, including look at the QRS duration, because the one thing we often do not do is if they've got a left bundle branch block or prolonged QRS, they deserve device therapy. It's not that they should earn it, they deserve device therapy. And additional therapies like Vebradin is 2A, Vericiguat is 2B, digoxin is 2B, potassium binders is 2B. CRT indications I won't go into, but suffice to say that if you do not give it in the right patient at the right time, you are doing harm to the patient. Having said that, what does ARNI do? ARNI has reduced the workload of electrophysiologists, and EP people are now going to be inundated with atrial fibrillation. So PROVE-HF showed that people EF less than 35%, their 32% their ejection fraction improved more than 35% by 6 months, and whopping 62% by 1 year. So Dr. Mandeep talked about the arbitrary 90, all those things, but now we have simply some RCT data that we can even wait, especially in non-secondary heart failures, or the not for primary prevention. You can try ARNI, see whether it improves. Then additional therapies, including MitraClip, but assess the patient, make sure that at GDMT. In COAP trial for MitraClip, 1/3 of the patients they had to be refused to be part of the trial because they were not on guideline-directed medical therapy. We have people airlifted from many parts of the country have come for MitraClip. We initiate guideline-directed medical therapy, including ARNIs, and nearly 30% of them, their MR reduces. And there's a prime-HF trial with ARNI which shows that MR reduces. And sometimes they are very disappointed. They came in air ambulance, spent lakhs for that, and we say that it's not necessary. Your heart is improved, your leak has come down. Very unusual to see people actually disappointed with improvement of their condition. They think, doctor, why don't you put, like Dr. Maninder said, why don't do the MitraClip anyway? And we say 30 lakhs you can give to charity, and people, so at least 30% improve. So there are certain algorithms, follow the algorithms, that's important, because like these expensive things are not for everybody, should have protocols in place. I'm fond of amyloidosis, but we are picking up more and more. 1/8, this is US data, I think Mayo Clinic, 1/8 of the patients who undergo MitraClip have amyloidosis. but 15 to 16% of the people who undergo TAVR have amyloidosis. It's not to say don't do that, you have to do that, but importance has, if you miss that diagnosis, the prognosis becomes curtailed. So there is even a thought process, that's my talk in the CSI meeting, that should all patients with undergoing TAVR be evaluated for amyloidosis. That's a controversial topic. But look for it, because AL amyloidosis without treatment, life expectancy is 4 months. And again, Mayo Clinic data, TTR amyloidosis, life expectancy is 4 years. So, and we have treatment for that. Few new things, fluid restriction and salt restriction, we are giving it very aggressively. They have made it little more lax. Inotropic support. Again, we are very fond of, anybody comes with heart failure to the hospital, invariably people put on dobutamine, milrinone, but again, they improve the hemodynamics a little bit, but no improvement. This is the 2022 guideline. They can be used as a bridge, but then don't use it for every person. Decompensated heart failure, always look at the precipitating factors and optimize the patient. That brings me to Pioneer, because Pioneer is ARNI, hospitalized patients. And how long you have to stabilize? Just 6 hours. Stabilize them for 6 hours, add ARNI, and you can see a significant benefit, p-value significant, and this exploratory endpoint, but number needed to treat is 13. There are only few conditions with numbers needed to treat less than 15, and I know ICD is one of them, but that was in the pre-GDMT era. Then in hospitalization, start GDMT, it's a class 1 indication. Decongestion is important, very important. Atrial fibrillation, AF in heart failure are not going to, but what they say is 2A indication for ablation for reducing symptoms. Comorbidity is very important, sleep disorders, 2A indication, and iron deficiency, 2A indication, diabetes class 1 indication. Cardio-oncology should never be forgotten, because cancers are increasing, lot of new therapies which I cannot even pronounce, all of them will have some cardiac effect or not. Pregnancy, again, the importance is that AC inhibitors, ARNIs, MRIs, SGLT2 inhibitors, ivabradine and vericiguat should not be given because of harm. That is important thing. Now, comparing the different guidelines, I'll just focus on ARNI again. What they said, ESC said, as a replacement, class 1, de novo, class 2B, they said, okay, start ACE inhibitors. We know that that's not the better thing, but Americans, for a change, have been more aggressive than Europeans. They say straight away, you can switch. So that is one of the fundamental difference. Other differences I said, including ICDs, and again, the Americans are more aggressive on ICD, including primary prevention. So I conclude by saying that delayed initiation is needless exposure to increased risk. Time, we all know that time is money. We know that time is muscle intervention, but time is prognosis, and time is life in heart failure. And if you do not start them in time, you will never end up giving them. So I close with my last few slides. ARNI in all outcomes of heart failure. If a person is on ARNI compared to ACE inhibitor, not compared to placebo, because placebo is the very, again, low-hanging fruit. Compared to ACE inhibitors, patients are less likely to die of cardiovascular cause, less likely to die suddenly, less likely to be hospitalized, less likely to show symptomatic deterioration, less likely to need intensification of oral therapy, less likely to show deterioration in renal function, less likely to visit the ER, less likely to visit the ICU, less likely to require devices, less likely to show biomarker evidence. So many of our patients may be on ARBs, which I feel is not the right way to go about it. But if you have to replace, this is a question everyone asks. So the replacing ACE inhibitors or ARBs with ARNIs, is it important? Yes, because it is clinically significant. The effect is statistically extremely robust. Benefit is absolutely worthwhile. It's consistent across subgroups, including the elderly. The benefit is incremental, and it's tolerated well and safe, and it's reasonably easy to use. It is cost effective. Again, the guidelines are Americans have said that it is cost effective, and the early initiation is more cost effective. I conclude by this slide. So, standard of care. Heart failure remains a clinical diagnosis that requires you. That means you and me. The understanding definitions and stages creates intentionality. We should have the intention to treat. Patients deserve treatment. Patients should not earn treatment. Prevention and risk stratification are important. 4 pillars works and they save lives. Inertia is deadly. We need to stop labeling patients as non-compliant. I have learned to believe that there are true non-compliant people, but biggest problem is we do not chase them enough. Identify and treat comorbidities, including sleep disorder, and recognize special cohorts. And this is my concluding slide, and this is relevant to us as a doctor or as AC RNAs. No matter how good you are, you can always be replaced. You can replace, you start AC RNAs at the earliest, because I don't think the younger generation would have seen the old phone. Thank you very much for patient hearing.
Dear friends, there are certain occasions we come across in life, very difficult and challenging occasion. That is one such occasion now is to face this CME program, that to more oriented with ECGs to see after the heavy lunch. It's a challenge, but Dr. Oomman, Abraham Oomman from Apollo Hospital, I have forgotten to introduce him. He's a senior consultant from Apollo Hospital, Chennai, well experienced. He has highlighted now all the new guidelines of ACC 22 and ESI 21.